we would like to invite the conference chairs, Professor Yilong Wu, Professor Nicolas Girard, and Professor Yong Song to deliver the opening remarks.
Hi, good evening, good afternoon, Professor Zhang and medical chair, the Dr. Sean and the Dr. Zhou and Dr. Liu and everybody. So welcome to join the best of the ESMO. So today we do have the talk about the EGFR mutant patient in the first line, the combination treatment. I think this is a very interesting topic in the recent 2 years because now we have some clinical trials, so they have the strong evidence that this combination could prolong the PFS and the overall survival. So I think this is very hope the very interesting topic, and welcome everybody to join our the meeting. Yeah, thank you.
Well, thank you for the invitation today. So I'm Nicolas Girard, working at Institut Curie in Paris, and yeah, eager to have the discussion with you around this very important topic.
Good evening, Professor Wu and colleagues. Good afternoon to our colleagues in Europe. It's my great pleasure to welcome you all in this special session based on ESMO Precision Oncology in Lung Cancer China series. I'm Dr. Yang Song from Jingling Hospital, Nanjing University. For first-line therapy of non-small cell lung cancer patients with EGFR mutant, we have seen rapid evolution just from single-agent TKIs to combination therapies. So tonight, we're not here simply to review the latest data from ESMO, but we have to ask hard questions. I do hope everybody here to enjoy the meeting. Thank you.
Okay, so I think that tonight we have the first speaker from the friend, Professor Nicolas Girard. So he will talk about from efficacy improvement to treatment choice, the evaluation of the first-line treatment landscape in the EGFR mutant non-small cancer. So please, Dr. Girard. Yeah.
So,
yeah, Nicolas, you are on it.
Okay,
yeah,
thank you. I'm sharing my slides. I think it's okay for the sharing. So yeah, today my talk will focus on first-line options for patients with EGFR-mutated non-small cell lung cancer. So we know that this is a subset of patients in Europe, and I put here the frequency in my country. Clearly, it's obviously a situation that is far more frequent in China, and we have a lot to share together. In Europe, the standard of care for first line is based on the FLAURA trial. So FLAURA was osimertinib versus the first generation TKI, gefitinib, erlotinib, in those patients with common EGFR mutations. And FLAURA demonstrated the benefit with osimertinib to prevent the emergence of secondary acquired mutations, and also to cover probably the CNS disease, as CNS disease is a frequent pattern of disease progression in those patients. In the ITT population, we have a PFS moving from 10 months to 19 months, and this benefit is actually translates into an overall survival benefit from 32 months median to 39 months, showing and highlighting the fact that the first line is a major component in the overall survival of the patients. Most of the expected lifetime of the patients is spent while receiving first-line treatment. And this is because of the impact of first-line, but also related to the fact that there is an attrition. We lose patients from first-line to second-line because some patients show disease progression with a rapid degradation of the general condition and do not receive subsequent line. So this explains why first-line treatment choice is so important in the clinical practice. We also see in FLAURA the impact of CNS disease. Here we see a benefit with osimertinib, not only in patients with CNS metastases at baseline, but also in patients without CNS disease at baseline. The magnitude of benefit is quite similar in the two groups of the patients. And again, it highlights how CNS disease and the CNS PFS is important for the contribution to the global PFS of the patients. After osimertinib, let's move a little bit to second line to understand how we can move to first line with innovative options. And historically, after osimertinib, the second line treatment is based on chemotherapy, usually carboplatin and pemetrexed. But here, the median PFS is quite limited, 4.5 months, median OS around 9 months. Here, I do not discuss today the opportunities for local ablative treatment for oligo-progressive disease, but if you have to move to second-line treatment, this is the figures for chemotherapy. Obviously, if it's possible, it's important to do a rebiopsy, and we may identify some of the resistance mechanisms to osimertinib, including secondary mutations in the kinase domain, including the bypass to the activation of MET or EGFR, or the histologic transformation. Chemotherapy, we have seen very nice data at WCLC 2025 from the COMPEL study comparing continuation of osimertinib or switch to chemotherapy. So when you have disease progression after osimertinib, should you continue osi or discontinue osi? Remember about the very old IMPRESS trial with gefitinib, where the benefit of continuing gefitinib when starting chemotherapy was not demonstrated in that old study. With osimertinib, probably the story is a little bit different with a higher efficacy on the CNS, and we see a benefit with the continuation of osimertinib. So chemotherapy plus continuation of osimertinib is doing better than switch to chemotherapy, moving from 4 months and a half to 8 months and a half. So this is quite relevant for this subgroup of patients without disease progression in the CNS after osimertinib. This is an academic trial. I'm not sure it is a basis for a clear registration of this option. Still, it shows that it is mandatory and beneficial to continue EGFR inhibition when starting second-line treatment. And this is something that is done in clinical practice in some of the patients. Actually, probably the best way to continue with the inhibition of EGFR signaling pathway is to use a more potent inhibitor, amivantamab. Amivantamab, this bispecific EGFR-MET antibody, so not only EGFR but also MET, and also a coverage of all the potential resistance mechanism part of EGFR or MET. This is a Mariposa 2 trial. chemotherapy plus amivantamab in blue versus chemotherapy after progression while under osimertinib. We see here a benefit in terms of PFS, hazard ratio 0.48, so reduction by twice of the risk of disease progression, moving from 4.2 months to 6.3 months, with a tendency towards an overall survival benefit. So adding amivantamab to chemotherapy provides a benefit in those patients. And we know that the safety of chemotherapy plus amivantamab is related to the mechanism of action of amivantamab with frequent rash, peripheral edema, and also obviously the hematological toxicity related to chemo. So we have multiple options in the second line setting. I discussed amivantamab, continuation of OSI, but you have access to ivonescimab plus chemotherapy. We know that antibody-drug conjugates such as sacituzumab tirumotecan have shown a benefit in this setting post-osimertinib, in the third-line setting, in the second-line setting. Datopotamab deruxtecan is also available in the US. So there is a lot in the second-line setting, but as I discussed, the most important choice is the first-line setting. And in the second-line setting, even if you have a 2 months, 4 months benefit, it remains quite limited. So maybe it's better to have these options integrated into the first-line treatment regimen. And this is the data that we have seen over the past months. We know that at baseline, at the time of diagnosis, we have a frequent feature of aggressiveness in those patients, including brain mets in 1/3 of the patients, TP53 commutation, baseline ctDNA positive. So this is aggressive disease, and so this is why we need to intensify, to escalate the treatment from single agent osimertinib to combination regimen, integrating the options that we have been used to administer in the second line setting. FLAURA2 is the first way to do that. FLAURA2 is osimertinib plus chemotherapy. So FLAURA2, osimertinib plus chemo with carboplatin pemetrexed and versus osimertinib as a control arm in those patients with common EGFR mutation, primary endpoint PFS. And we see a benefit. When we escalate, when we add chemotherapy to osimertinib, we have this benefit moving from 16.7 months to 25.5 months median. Quite immediate benefit. You see how the curves are separating quite early. The benefit is observed across all the subset of patients and probably with a higher magnitude in patients with aggressive disease, including patients with brain metastasis at baseline. You can see that when you had chemotherapy, you move from 14 months to 25 months in this subset of patients. So clearly, the magnitude of benefit with the intensification is very clear in those patients with aggressive disease. Maybe in patients with less aggressive disease, the magnitude of benefit is lower. This is exploratory, obviously, but here we see, for example, in patients without CNS metastasis, maybe the difference is a little bit lower than what we have in the patients with more aggressive disease. Sorry, okay. What we see also, and same thing that we had seen in FLAURA, when we have this benefit in the CNS in patients with CNS disease, we see that we clearly improve the global outcome. Again, here another exploratory analysis of the FLAURA2 trial showing that in patients with 3 metastatic sites or more, we have a very clear benefit, 16 months to 25 months. In patients with kind of oligo metastatic disease, less aggressive disease, maybe the magnitude of benefit versus single agent osimertinib is a little bit lower. When we do chemotherapy first plus osimertinib, what is the treatment at the time of disease progression? In the FLAURA2 trial, 44% of the patients did receive a kind of a re-challenge with platinum-based chemotherapy. 30% of the patients got single-agent chemotherapy, and the rest other options. We have seen at recent ELCC meeting some of the data about this chemotherapy re-challenge after FLAURA2, and this is a table from this poster presented at ELCC. In the patients who had a re-challenge with platinum-based chemotherapy, one question was around the chemotherapy-free interval, of the pemetrexed-free interval, and the hypothesis was that a prolonged chemotherapy-free interval would predict a higher efficacy or higher duration of efficacy of chemotherapy re-challenge, but this is not that clear from the data that we have seen from the FLAURA2 trial. So not sure that this chemotherapy-free interval is something relevant in the clinic. At the end, we have an overall survival benefit. So again, we see PFS benefit in the first line translating into an overall survival benefit in the overall survival of the patients, moving from 38 months to 48 months median. And you can see that this magnitude of overall survival benefit is observed along with the follow-up of the patients. In terms of safety, well, we have the side effects of chemotherapy, especially during the first months of treatment, and the side effects from osimertinib. One clinical point in my practice is to pay attention to the hematological side effects, especially the risk of neutropenia. And in my practice, I prescribe GCSF prophylactic for these patients. Obviously, the duration of chemotherapy is limited, 4 cycles with carboplatin and 8 to 10 cycles with pemetrexed. We clearly have here a quite prolonged duration of treatment without chemotherapy, and there are many questions, as I discussed, with this chemotherapy-free interval. But most of the side effects are actually observed during the first 4 months of treatment. Ultimately, adding chemotherapy to osimertinib does not change the resistance mechanisms to osimertinib. Activation of MET, activation of BRAF, secondary EGFR mutation. So we want to apply the second-line strategies that have been described post-osimertinib to those patients, pending that chemotherapy re-challenge is feasible. The other way to intensify treatment in the first-line setting is to use the amivantamab that had shown this efficacy in the second-line setting to the first-line setting, and this is a Mariposa regimen. Mariposa is amivantamab plus lazertinib, which is a third-generation TKI, and this combination, the dual inhibition of the EGFR, was compared to osimertinib in the first-line setting, and this is a Mariposa trial. Here, amivantamab was delivered intravenously every 2 weeks. We have a benefit with the combination versus osimertinib. This is a primary endpoint. Again, moving from 17 months to 24 months median, a clear separation of the curves, quite similar hazard ratio to what we have in FLAURA2. We see a benefit across all the subset of patients, not only the patients with aggressive disease, but also the patients without such features of aggressiveness. We see a benefit in patients with or without brain mets, with or without liver mets, with or without TP53 mutations. We also see that we prolong the CNS intracranial PFS with amivantamab plus lazertinib, and this is probably a benefit that we see long term. But here in this study, there was a really close monitoring of CNS disease. And finally, we keep the opportunity for platinum-based chemotherapy in those patients, because this is a chemotherapy-free regimen. So most of the patients, they go to receive second-line platinum-based chemotherapy post-Mariposa. We see that this PFS benefit translates into an overall survival benefit. We do not have the median in the amivantamab plus lazertinib arm, but it's expected to be more than 1 year. So again, we see that we increase the survival of the patient. With the dual inhibition of EGFR, we have frequent side effects related to EGFR inhibition, so mostly the rash, the paronychia, so it requires a specific management for these side effects, including prophylactic regimen. MET inhibition-related side effects are less frequent, but we may see some patients with peripheral edema. Again, so side effects are most common in the first months of treatment. We know that we can decrease the dose of amivantamab, and this does not preclude efficacy, at least in terms of PFS, based on these data. So to me, this is one way to go with management of the side effects with amivantamab. Obviously, we have the prophylactic regimen against those side effects, but we may decrease the dose, and this is secured without a loss of efficacy. Amivantamab plus lazertinib, we are modifying the natural history of the disease because we have the MET amplification and we have this deep inhibition of the EGFR signaling pathway. So the mechanism of resistance are completely different to that reported with osimertinib. Less MET amplification, less acquired secondary EGFR mutations. We know that amivantamab now is available or will be available with a subcutaneous formulation, which will facilitate the administration. It may be done every 2 weeks or every 4 weeks. With a sub-Q, we have less infusion-related reactions, which are quite frequent with intravenous amivantamab, but may be reduced with the use of dexamethasone for 3 days before the first injection. But at least it facilitates probably the safety. Here are the data with amivantamab every 4 weeks. Similar response rates as what we have with IV amivantamab, and clearly a better safety profile, not only in terms of infusion-related reactions, but in the most recent cohorts, better safety in terms of cutaneous side effects, probably because of the awareness of the investigators and the experience they gained with this compound. We obviously have then several options to escalate, FLAURA2, Mariposa. How to choose? Well, we probably have to integrate patient-centered factors, the age, performance status, the comorbidities, disease-centered, CNS disease, aggressiveness of the disease, and probably some biological features, the type of mutation, but the co-mutation, TP53 is probably a very important feature for that. We also know that it's very important to consider this intensification for the majority of the patient, and probably osimertinib as a single agent will be reserved to patients not amenable to intensification. It's very important not only to consider the response, but also the duration of response and the deepness of the response, as well as the side effects. And we know that with chemotherapy, we have, especially during the first months of treatment, to integrate vitamins with pemetrexed, antiemetic agents. We have to give G-CSF, and this is my practice in a prophylactic manner, especially for elderly patients. With amivantamab plus lazertinib, this is prophylaxis for infusion-related reaction, especially if we go with IV amivantamab. It will be reduced when using subcutaneous amivantamab. The dermatologic prophylactic regimen with doxycycline, clindamycin lotion, and moisturizor, Baume Lipicar being my preferred choice in clinical practice. We also need to include prophylaxis for venous thromboembolism, which have been reported during the first months of treatment with amivantamab plus lazertinib. it's feasible. We have seen this data from real-world cohorts in Gustave Roussy and from Italian centers, highlighting the fact that in most of the patients with dermatologic prophylactic management, it's possible not to discontinue amivantamab, to continue amivantamab even with a dose reduction, but for the majority of patients, the safety will be manageable. We have the ongoing Copernicus study, which will include subcutaneous amivantamab, VT prophylaxis, skin prophylaxis, and we will then get more figures regarding the management of those patients. Back to the ESMO clinical practice guidelines. Amivantamab plus lazertinib is recommended as a preferred option. Osimertinib plus platinum-based chemotherapy is also recommended as a preferred option. MCBS 4 for AMI plus laser, MCBS 3 for OSI plus chemotherapy, and then single agent options. So many data, a new way to envision the treatment strategy for the first-line treatment of the patients using combination therapies, chemotherapy-based FLAURA2 or chemotherapy-free Mariposa. Obviously, we have an impact on what we will do in the second-line setting. It's very important to optimize the safety of these regimens because the patients will receive this treatment for a prolonged duration. And the shared decision-making is very important to integrate obviously the clinical data, the biological data, but also discuss with the patients. And with that, I will stop here, and I thank you for your attention.
Yeah, thank you so much, Dr. Girard, so for your excellent talk about the EGFR-mutant patient, how to use in the first line, and then how to balance the patient, the factor, and biology and the disease, the characteristics. I think we have the more the discussion point in the panel discussions. So thank you so much for your excellent talk. Now we are invite the Professor Jin Zhao from the Beijing Cancer Hospital. You with the talk about the safety and management, the first like combination therapy, key consideration and the response approach. Yeah, please, Dr. Zhao. Yeah.
Okay. Good afternoon and good evening for all the experts. It's my pleasure to share some data of the how to management of the safety issue. Okay. Let me share. Okay. 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 Professor Girard has shown us the about the first line of the EGFR mutation patient. For the combination therapy, I think is the best choice right now. And for all the guidelines has shown us for the EGFR mutation patient first line, chemo plus the osimertinib or the amivantamab plus the lazertinib should be the first line recommendation. So even for the subsequent therapy of the EGFR mutation patient, after the progression of the multiple lesion, the carboplatin plus the pemetrexed and the amivantamab should also provide a very good efficacy of this kind of patient. But I think for this combination, provide patient good efficacy, but we also should think about how to improve the efficacy, and safety issue should be taken serious. If the combination lead to the patient complex toxicity, it will reduce the quality of life of the patient. It also will have the make patient have the dose reduction, dose interruption, and discontinuation, and it also maybe shorten the treatment duration, limiting the efficacy. So let's see the amivantamab plus the lazertinib. The common adverse event were grade 1 to 2 and occurred most frequently during the first 4 months. So after the 4 months, the incidence of the adverse event significantly decreased. So I think for the patient and even for the doctors, it's easy to management. If we use the amivantamab plus the chemotherapy, we also will find the different kind of the side effect, such as some of the adverse event is associated with EGFR inhibition, such as pyronychia and rash and diarrhea. Some of the adverse events are associated with MET inhibition, such as hypoalbuminemia and peripheral edema. And some of the patients will have the adverse event associated with the chemotherapy. So for this kind of combination, the results from the studies show us the neutropenia and the thrombocytopenia most occur in the cycle 1. The incidence of the febrile neutropenia was very low, about 2%. But the incidence of the VTE was similar between the combination group and the chemotherapy. It's around the 10% for the any grade. And the LD of the incidence was very low, both of the ACP group and the chemotherapy group. So next, we will one by one to take a look for the different kind of the adverse event. The first is the dermatologic adverse event. This adverse event occurred in the first 4 months. So it's suggesting that the early intervention is very important to reduce the incidence and improve the tolerance. So there is a systematic review and to evaluate the tetracycline antibiotics as a prophylactic measure against the skin toxicity in patients treated with the EGFR inhibitors. It shows prophylactic tetracyclines in the anti-EGFR treatment patient will reduce the risk of the moderate to severe rash by 64%. So this tetracycline treatment are common used for the different country, the guideline to how to management of the acne. Here show the detail of how to use the oral antibiotics and the dose and the duration of the treatment. Because the time is limit, I will not to take the detail. There also a Cancun study is aimed to explore the accessible and convenient dermatologic management strategy to reduce the incidence of the dermatologic adverse event. This is a global open-label randomized controlled phase 2 study aimed to evaluate the impact of the enhanced dermatological management on the incidence of the dermatological adverse event among the patients received the first-line combination of the amivantamab and the laser. So they use the oral doxycycline or minocycline for the week 1 to week 12. And they also use the topical clindamycin lotion on scalp for the week 13 to the week 52. For the arm B, is use the standard management. For the cocoon regimen, it's significantly reduced dermatological adverse event. For the cocoon group, the incidence is just the half of the compare of the standard of care. So compared with the standard of care, the incidence of the grade 2 dermatological adverse event was reduced by twofold. And the incidence of grade 3 dermatological adverse event was reduced by the also by the twofold. The incidence of the more than 2 different type of the dermatological adverse event was reduced by threefold. So the cocoon regimen significantly reduced the adverse event, no matter the facial adverse event and body and scalp and the perineum. So here is also show the incidence of the grade 2 dermatological adverse event in the first 12 weeks is significantly decreased, about 45%. No matter facial, body, and the scalp, pericornea is also decreased with the Asian population. It's also this study is also show the reduction of the patient report of the dermatological adverse event severity and enhance the quality of life with the combination therapy. No matter the rash, skin condition, and nail infection is also decreased. The regimen also improved the treatment compliance, allowing the patient to receive continuous and sufficient treatment. The tumor response status, the overall response rate is around 80%. So the incidence of dose adjustment due to the dermatological adverse event is also reduced. So for the patient quality of life, we also can see the concurrent regimen demonstrates significantly improved skin DEX, the total score. So the cocoon give us the 3-step strategy for the how to manage the dermatological adverse event. The first phase is the prevent the adverse event. Can reduce the incidence of the more than grade 2 the adverse event. The phase 2 for the patient with the new onset or persistent dermatological adverse event, they have the treatment sub-studies for the treatment patient. They use the ruxolitinib cream and tacrolimus ointment. For the concurrent expansion cohort, they optimize the patient use the subcutaneous amivantamab and evaluated efficacy prophylactic management strategy and early intervention for the dermatological adverse event. That study is ongoing. So for the sub-study, the Cocoon treatment sub-study, they further explored the efficacy of the intervention treatment for the new onset or persistent grade 2, more than grade 2 dermatological adverse event. Used 0.1% tacrolimus ointment, topical twice daily for up to 12 weeks. So for this group, we can see use the treatment. 63% of patients responded to the tacrolimus treatment, and 38% achieving complete remission. And the median time to dermatological adverse event improvement was the 2.3 weeks. The second, we will see the infusion-related reactions. As we know, the amivantamab associated the infusion reaction occurred mainly with the first infusion, with incidence decreasing markedly thereafter. The key symptom of the amivantamab associated the infusion reactions, such as the fever, nausea, hypotension, and the dyspnea as well. And among the amivantamab treatment patients who experienced infusion reactions, 97% were grade 1 or grade 2. The median time to onset of the infusion reactions after the amivantamab is around 1 hour. So that if we're familiar with these infusion reactions, I think it's very easy to management. Here, the right picture show us the instance from the different clinical trials of the amivantamab combination treatment. We can see the more than grade 3 adverse event is very low. It's around 5%. So I think the whole process is very important. How to administration of the pre-infusion prophylactic medication is very important for us to reduce the risk of the amivantamab associated infusion reactions. It's including some medication such as the antihistamine treatment and antipyretic treatment and some dexamethasone prophylactic medications. So the right picture also show us how to monitoring the intrafusion reactions for the grade 1 to grade 4. You should focus on the grade 4 patients will be permanently discontinue the amivantamab treatment. But if the grade 3 infusion reaction recur in the subsequent infusion, it also should be discontinued. So there are another study named SCIP here to management how to use the prophylactic dexamethasone to reduce the intrafusion reactions. In the dexamethasone 8 milligram group, the C1D1 infusion reaction incidence dropped to 22.5%. It's just 1/3 of the historical data. And all the events were grade 1 to grade 2. No serious adverse event occurred. So the patients on the advanced SCIP here management protocol experienced fewer infusion reaction related symptoms. As we know, we have now we have the subcutaneous formulation of the amivantamab. The Paloma 3 has improved administration of the convenience and reduced the infusion reaction incidence. The rate is just about 13%. And last, let us to look at about the VTE. Based on the studies of the Mariposa, we can see the VTE, the median time to first VTE days is 84. The incidence of the VTE is more than grade 3 is just 11%, but it's lower in the Mariposa 2 study. For the CISCO guideline has recommended the prophylactic anticoagulation for the high risk of the VTE patient. There is a Corona score will show us the separate the different kinds of the risk of patient. For the high risk patient, no matter the CISCO and the ASCO guideline also recommend the prophylactic anticoagulation for our patient with the high risk patient. The Paloma 2 study is also show us the prophylactic anticoagulation treatment can reduce the VTE incidence with the ME plus the laser treatment. So this two cohort about show us the result. The VTE incidence is just 11%. So for amivantamab associated, the adverse event has shown us from different studies, we can see the Cocoon regimen has significantly reduced the more than grade 2 dermatologic adverse event. But for the Scipio regimen has significantly reduced the infusion reaction. The incidence is lower for just 20%. And for the ME plus laser treatment, prophylactic anticoagulation treatment is very important. It can reduce the VTE for 45%. So here show us the amivantamab treatment regimen, including the prophylactic management strategy for the adverse event. For prior to the treatment, from 2 days before treatment until 1 hour pre-infusion, we need ask the patient to take the dexamethasone for the prophylactic infusion reactions. After treatment initiation, we also for the ME plus laser patient, we should take the prophylactic anticoagulation treatment for the first 4 months of the treatment. And the Cocoon regimen, including the antibiotic prophylaxis and the nail cleansing and the long-lasting skin moisturization, that should be important for the patient to management the dermatological adverse event. So I think if the patient want to get the long-term survival, I think not just for the efficacy, the safety is also important for the patient. That's all for the presentation. Thank you for your attention.
Yeah, thank you, Dr. Zhao, for your comprehensive presentation, how to manage the side effect and how to prevent the safety, the treatment. So I think this also we will the discussion in the panel, the session. Now I will invite Dr. Song Yong to moderate the next session. Yeah, please, Professor Song. Yeah. 宋勇在吗？
Oh, I'm here. Yeah. Oh, dear professors, now I'm very happy to invite Professor Felip to give us a speech. Professor Felip from Spain. She's president Spanish Society of Medical Oncology. So she will give us the topic about from resistant mechanisms to sequencing decisions, rethinking strategies for subsequent life therapy. Professor Felip, please.
Yes, thank you, Dr. Thong. Thank you, Dr. Hu. It's a real honor for me to be here today and to discuss with you this important topic of the treatment in patients with EGFR mutation. So thank you for the invitation. So in my presentation, I'm mainly focused on second-line treatment strategies. So you can see here my declaration of interest. So it was mentioned by the previous speakers, it's important that for those patients receiving first-line treatment, there is a need to perform a rebiopsy or liquid biopsy at disease progression in order to analyze the mechanisms of acquired resistance. In this slide, you can see the results of a study in which patients with EGFR mutations receiving osimertinib underwent a rebiopsy. And the main message here is that the rebiopsy was feasible in 36% of the patients. And overall, after osimertinib, the most frequent mechanism of acquired resistance was MET amplification, following by secondary EGFR mutations, mainly the C797S mutation. But there are other mechanisms of acquired resistance. It was also described, the MET deletion, and also is very uncommon, but there are patients with ALK fusions or RET fusions. Here you can see the results of mechanisms of acquired resistance in the FLAURA2 trial. Overall, there were no differences in the mechanisms of acquired resistance for those patients receiving osimertinib monotherapy or osimertinib plus chemotherapy. Again, the most frequent mechanisms of acquired resistance were MET amplification, secondary EGFR mutations, and uncommonly, the authors reported BRAF V600, BRAF fusions, RET fusions, or ALK fusions. And also mentioned by Dr. Nicolas Girard in the Mariposa trial, comparing osimertinib versus amivantamab plus ertinib, we have seen that at disease progression, the percentage of patients with MET amplification as a mechanism of acquired resistance was lower when compared to those patients treated with osimertinib, and the same with the secondary EGFR mutation. So more patients in the osimertinib arm had secondary EGFR resistant mutations as a mechanism of acquired resistance comparing to those patients treated with amivantamab plus lazertinib. So in the patients with EGFR mutations treated with first line, I think we probably all agree that for those patients with oligoprogression, localized progression, we may consider radiotherapy and continuation of the prior treatment. However, in the presence of systemic progression, there is a need for rebiopsy, tissue is preferred, but if it's not possible, liquid biopsy. And we have different treatment options in this scenario. We may treat the mechanisms of resistance, for example, MET. There are also the possibility of chemotherapy plus bispecifics, and mainly I'm going to focus on chemo plus amivantamab and chemo plus ivonescimab, and also there are studies analyzing antibody-drug conjugates in this second-line scenario. So in general, if the mechanism of acquired resistance is ALK or RET or BRAF, it's that there are only some clinical cases in the literature, but we may consider to continue with a prior third-generation EGFR TKI plus the TKI inhibiting the mechanism of acquired resistance. But again, these are very small numbers. On the case of the analysis of osimertinib and selpercatinib in those patients with EGFR mutations with RET fusions as a mechanism of resistance, there was the analysis of only 14 patients. We have results of a randomized trial analyzing a MET inhibitor as a secondary treatment in second line for those patients with EGFR mutations, and also these patients were previously treated with EGFR TKI and with MET amplification as a mechanism of acquired resistance. And this study presented by Dr. Lu at ASCO 2025 compared in these patients with MET amplification the combination of savolitinib plus osimertinib or platinum pemetrexed chemotherapy. And the study showed that the response rate with savolitinib plus osimertinib was 58%, with chemotherapy was 34%. The median duration of response was 8.4 months with savolitinib plus osimertinib, 3.2 months with chemotherapy alone. Progression-free survival in the intention to treat population was longer for those patients treated with OSI plus savolitinib, with a median PFS of 8.2 months, 4.5 months with chemotherapy, with a hazard ratio for PFS of 0.34. It's true that the percentage of patients included in the trial previously treated with a third-generation EGFR TKI was relatively small, and it was analyzed. This was not the primary endpoint of the trial. In this subgroup analysis, the hazard ratio was 0.32. The other potential strategy in patients progressing after first-line osimertinib are the combination with amivantamab. There are the Mariposa-2 trial mentioned by Nicolas Girard, but also 2 cohorts in the Chrysalis studies. And overall, the rationale to give amivantamab, that as mentioned is a bispecific IgG1 antibody targeting EGFR and MET, is mainly the mechanism of action of this agent. It has been described 3 mechanisms of action: receptor degradation, immune cell directing activity, and inhibition of ligand binding. And the most important study in this second-line scenario is the Mariposa-2. In this trial, patients with sensitizing mutation progress after osimertinib monotherapy were randomized to receive chemotherapy alone, the control arm, or chemotherapy plus amivantamab plus lazertinib, or chemotherapy plus amivantamab. In the trial, stable brain metastases were allowed to be included, and there are 2 dual primary endpoints of PFS by blinded independent committee review: the comparison between amivantamab, lazertinib, and chemotherapy versus chemotherapy alone, and the comparison of amivantamab plus chemotherapy versus chemotherapy alone. We know that this is a positive trial that was presented initially at ESMO 2023. And the results show that the combination of chemo plus amivantamab improve PFS when compared to chemotherapy alone with a hazard ratio of 0.48. The combination of chemo plus amivantamab plus lazertinib improve progression-free survival when compared to chemotherapy alone with a hazard ratio of 0.44. Response rate was 64% with chemo plus amivantamab, 63% with chemo plus ami plus lazertinib, 36% with chemotherapy alone. And the median duration of response was also longer for those patients receiving chemotherapy plus amivantamab plus or minus lazertinib. Toxicity, overall, we have seen the toxicity with amivantamab. The Mariposa-2 was published before all the preventive measures previously discussed were considered. So it was described with chemotherapy plus amivantamab as probably approximately 37% of the patients with pyronychia, 43% of patients with rash, 58% of patients with infusion-related reactions. But again, this was before implementing all the preventive measures, also before using the subcutaneous formulation. There are some signs of activity of amivantamab intracranial. The intracranial progression-free survival was longer with ami plus chemotherapy when compared to chemotherapy, with a hazard ratio of 0.55. The median intracranial progression-free survival with ami plus chemo was 12.5 months. Very similar results for those patients receiving chemo plus ami plus lazertinib. And also, the intracranial progression-free survival among those patients with a history of brain metastases and no prior brain radiotherapy was also longer for those patients receiving chemo plus amivantamab. Dr. Popat updated the results of the overall survival of the Mariposa-2, and there was a clear trend towards an improvement in overall survival when compared to chemotherapy, with a hazard ratio of 0.73. The 18-month overall survival, the estimated, was 50% of the patients in the chemo plus amivantamab arm, 40% of the patients in the chemotherapy alone arm. And also the time to subsequent therapy, the time to treatment discontinuation, and the time to symptomatic progression was better in those patients receiving chemo plus amivantamab when compared to chemotherapy. And overall, chemo plus amivantamab has been approved by regulatory agencies for those patients receiving first-line, third-generation EGFR TKI at disease progression. The other bispecific with results in the area of setting of EGFR mutation is ivonescimab. Harmony A compare chemo plus ivonescimab versus chemo plus placebo in patients with EGFR mutations previously treated with third-generation EGFR TKI, and show longer progression-free survival with chemo plus amivantamab with a hazard ratio of 0.46. And importantly, the overall survival results, the final overall survival results of this study were presented last year. And overall, there was an improvement in overall survival for those patients receiving chemo plus ivonescimab when compared to chemo plus placebo, with a hazard ratio of 0.74. And there is the global phase 3 Harmony study, the same design, patients with EGFR sensitizing mutations that progress on third-generation EGFR TKI were randomized to receive chemo plus ivonescimab or chemo plus placebo. And in the trial that was presented in the World Conference in Lung Cancer last year in Barcelona, progression-free survival was longer with chemo plus ivonescimab in this scenario with a hazard ratio of 0.52, and there was a trend towards an improvement in overall survival that was not statistically significant with a hazard ratio of 0.79, but the study was not yet mature. The other agents that are being analyzed in this scenario, second line, are the ADCs. I'm going to start with Dato-DXd, a TROP2 ADC, and it was presented at ESMO Asia. The results of patients with EGFR mutations treated with Dato-DXd in the TROPION-Lung01, the randomized trial in second line comparing Dato-DXd versus docetaxel, and also the EGFR mutated patients treated in TROPION-Lung05, that includes also at least one prior targeted therapy treatment. So overall, there are 117 patients with EGFR mutations treated with Dato-DXd. The response rate was 42.7%. The median duration of response was 7 months, with a median PFS of 5.8 months and a median overall survival of 15.6 months. And based on this analysis, the FDA approved Dato-DXd for those patients with EGFR mutations after progression to third-generation EGFR TKI. There is also an analysis of the combination of osimertinib plus Dato-DXd in osimertinib-resistant patients. The results were very good. There was the analysis of 2 different doses of Dato-DXd, and now there is a confirmatory study in this second-line scenario in patients with EGFR mutations comparing platinum chemotherapy versus Dato-DXd plus osimertinib. Another important ADC is sacituzumab tirumotecan, sac-TMT. This is also an anti-TROP2 ADC, and it was the presentation and also a publication in the New England Journal of Medicine in patients with EGFR sensitizing mutations receiving third-generation TKI, and the patients were randomized to receive sac-TMT or platinum pemetrexed. In the trial, progression-free survival was longer with a sac-TMT when compared to chemotherapy with a hazard ratio of 0.49, and there was also differences in overall survival with a hazard ratio of 0.60. And as a toxicity, there were some cases of stomatitis, ocular surface toxicity, but no cases of ILD or pneumonitis were reported. And this drug, sac-TMT, was also being analyzed in the third-line scenario in patients with EGFR mutations after osimertinib and then platinum pemetrexed in the OptiTROP-Lung03. This is in the third line, and patients were randomized to receive sac-TMT or docetaxel. And the updated results of this trial were presented during the ELCC meeting. Progression-free survival was longer with sac-TMT when compared to docetaxel with a hazard ratio of 0.23. But also importantly, there was differences in overall survival for those patients receiving sac-TMT in comparison of those patients receiving docetaxel as the third-line treatment in patients with sensitizing EGFR mutations. We have a probably negative study with an ADC in the EGFR scenario, is the ERTENA-Lung02 trial. This is a study in patients with EGFR mutations treated with third-generation EGFR TKI and patients were randomized to receive patritumab deruxtecan, an anti-HER3 ADC, versus platinum pemetrexed. This was presented by Dr. Mock at ASCO last year, and the benefit in progression-free survival was probably minimal. The median PFS with Dato-DXd was 5.8 months, with platinum pemetrexed 5.4 months, and according to the discussion during the ASCO, probably there will not be more development of this agent in this scenario. Finally, another mechanism of acquired resistance may well be a small cell lung cancer transformation. It's true that the only way to diagnose that is if we perform a rebiopsy in these patients. There are no clear recommendations about the treatment of the patients with a small cell lung cancer transformation, but only to mention a recent report analyzing tarlatamab, the T-cell engager against DLL3 that has been approved in small cell lung cancer. There was this analysis of tarlatamab in patients with EGFR mutations and small cell lung cancer as a mechanism of acquired resistance, with only one patient with a response. So I think this is my last slide. It's true that, as I mentioned by Dr. Girard, now we're clearly moving to the combinations in first line, and this will change the treatment in second and third line. But we have still a number of patients that have received only third-generation EGFR TKI as the first-line treatment approach. There is a need to perform a rebiopsy or liquid biopsy at disease progression. I would say that for those patients that are uncommon with ALK or BRAF or RET as a mechanism of acquired resistance, we can continue the previous TKI and add the tyrosine kinase inhibitor inhibiting the new alteration. In my opinion, if amivantamab has not been used in first line, it is clearly active in second line, and we have seen the results of the MARIPOSA-2 with chemo plus amivantamab. Of course, we need to implement all the preventive measures just discussed in the previous presentation. We have very good active agents also in this space, and I would like to highlight chemotherapy plus ivonescimab, Dato-DXd, and also safituzumab tirumotecan as a very active agents in this scenario. And in the case of histological transformation, we probably consider platinum etoposide probably with a continuation of the prior EGFR TKI, and we have some data suggesting that tarlatamab is not effective. And again, thank you so much for your kind attention.
Thank you. Thank you, Professor Felip, for your great presentation on resistance and sequencing. So now we have to move into the most interactive part of tonight's panel discussion. So we have 11 distinguished professors joining us online. So, but we just have 20 minutes. So I will guide us through 3 questions. So please keep your comments concisely so we can hear from as many as voice as possible. So we were talking about how to prolong the OS of EGFR-mutant non-small cell lung cancer, and how to balance the efficacy, safety, and patient characteristics and the sequencing. So I would like beginning to the first question. So in first-line therapy, we have multiple options now available, such as third-generation TKIs alone, and TKIs plus chemotherapy, or amivantamab plus lazertinib, etc. So what is your single most important consideration to prolong the overall survival? So the discuss order, I think we just follow the name list in this agenda. So Professor Yilong Wu will be first. What do you start? Then Professor Meng Xue and Professor Su Chenxia, please. Professor Liu, are you here? Are you there?
Okay. Thanks.
Okay, thank you.
Professor Su. Dear Professor Wu, and dear Professor Nicolas Girard, and dear Professor Felip. It's my honor to attend today's meeting. As we have discussed in today's meeting, the treatment strategy for EGFR-mutant non-small cell lung cancer patients is no longer a single choice. Instead, clinical evidence from FLAURA2 and MARIPOSA shows the first-line treatment landscape for advanced EGFR-mutant non-small cell lung cancer has a significant shift from monotherapy to combination intensification in recent years. And it has become an individual decision that requires comprehensive consideration of efficacy, safety, patient characteristics, and sequential treatment strategies. And just from the data shared today, I would like to share my perspective. Because the time is limited, so I only express my comment and simply. As for which combination is preferred in first-line treatment, I think FLAURA2 and MARIPOSA are current approved options. I think FLAURA2 and MARIPOSA represent two different combination strategies. The former is TKI plus chemo, and the latter is dual-targeted combination plus bio-specific antibody. And the characteristic of their clinical evidence, difference of their toxicity profiles, and their implications for clinical decision-making and warrant analysis. First, I think the efficacy, both trials achieved dual positive results of PFS and OS. However, it is important to note that the two trials are not directly comparable, as they differ in inclusion and exclusion criteria, and follow-up duration and patient composition. Both represent the best currently available outcomes for first-line treatment for advanced EGFR-mutated non-small cell lung cancer. And second, the safety and tolerability are the core difference between the two approaches. FLAURA2 utilizes a TKI plus chemo, and the incidence of more than 3 grade adverse events is primarily driven by chemo-related myelosuppression. Although manageable and reversible, tolerability poses a real-world challenge for elderly patients, those with poor PS scores or those with significant comorbidities. MARIPOSA employs a chemo-free, dual-targeted combination that avoids chemo-related hematological toxicity, but is unique dermatological toxicities. IRR and VT risk require prophylactic and management strategy. Although subcutaneous formulation improvement is a safety profile, but it is expensive and patient accessibility is insufficient, particularly in Chinese. And the long-term safety data are still being accumulated. Third, in terms of identifying optimal patients, I think patients with poor baseline prognosis, for example, TP53 co-mutation, subgroup analysis from FLAURA2 and 2 phase 3 trial close to and the top study demonstrated that such patients benefit from combination with chemo. And the patients who wish to preserve chemo and delay chemo exposure. The chemo-free model of MARIPOSA, I think, offers an alternative pathway for patients who have afraid of chemo. wish to defer its use and worry about chemotoxicity. For example, elderly patients, those with poor PFS scores. From the impact of subsequent therapy, each approach has its advantages and disadvantages. FLAURA2's combination chemo, while increasing early toxicity, doesn't explore the subsequent treatment options. Chemo exposure is limited, and the patient retains the ability to tolerate chemo upon progression. The resistance mechanism is similar to that of osimertinib monotherapy, providing a clear path for post-resistant precision therapy. But mariposa, on the other hand, completely preserved the chemo strategy. However, its post-resistance precision treatment strategy remains unclear and requires more real-world data to guide subsequent choice. Anyway, I completely agree with Professor Nicolas Girard's perspective. That is, use of combination therapy in the first-line setting should be considered or at least proposed for patients to maximum survival benefit. Shared decision-making with patients can lead to more informed, personalized, and ultimately more effective treatment decision for non-small cell lung cancer. That's all my comments. Thanks, Professor Song.
Thank you, Professor Liu. Then Professor Min.
Okay, thank you, Professor Song. Dear Professor Long, Professor Song, and Professor Phillips, and every professors, good evening and good afternoon. It's my honor to attend this meeting, and this is the first time for me to attend the English meetings. So maybe my English is not very good, but I will try to speak English to give us every professor my ideas for the to maximize the overall survivals in patients with EGFR-mutant advanced non-small cell lung cancer. Just Professor Song says I would like to speak from efficacy and safeties effect to see. So I think we should, based on the key phase 3 trials such as FLAURA2 and Mariposa. For the FLAURA, we know that it established osimertinib as the standard first-line single agent EGFR TKI with a median overall survival of 38.6 months and superior CNS activity compared with the first generation TKIs. But for the FLAURA2 demonstrated that osimertinib plus chemotherapies further improved overall survival to 47.5 months versus with osimertinib alone, with significant prolonged PFS and prolonged PFS. Just now, I listened Professor Rickett give us that Mariposa showed that the two target drugs two target drugs achieved a median overall survival of 48.7 months versus with osimertinib. It shows that the first chemo-free regimen with super overall survival over osimertinib, but we know that maybe it showed us that first-line combination strategies and super overall survivals combined with single agent osimertinib which in turn is superior to first generation TKIs. But from Mariposa to compared FLAURA2, the two double target drugs compared to many tips plus chemotherapy, which one is more favorite for the EGFR mutation patients? Maybe I don't know. So, but for the safety balances, we know that osimertinib monotherapies has the most favorable safety profiles, but plus chemotherapies maybe increase many other adverse evidence. And from the Professor Girard shows that the two target drugs is also is chemo-free, but has higher risk of skin toxicity, such as skin toxicity. So for the patient selection, maybe for the high-risk patients, such as CNS and L21 mutations and high tumor burdens maybe benefit from the frontline combination regimens, such as plus chemotherapy or just two target drugs. For the low-risk patients, such as elder patients, maybe we chose just one target. Thank you.
Dr. Song, I think
Yes.
we have the so limited time, but
Yeah,
we
right.
only the 4 minutes.
Time
So
is a
I
limit.
think can we ask some question to the Nicolas or the Felip, and then I
Okay.
think this is important. Not that everybody show the point. So I would ask the Nicolas. I just saw your presentation, the guideline from the ESMO also continue to recommend the first generation TKI, the gefitinib plus the chemo as the first line treatment. So I want to ask why the ESMO continue recommend this combination. Yeah.
That's a very good question. I'm not part of the ESMO, but I think it has to be revisited, and this is no more a standard of care given the FLAURA2 data. And this is always the issue with the guidelines. It's implementation of new strategies, but sometimes we need to think about deleting some of the strategies that are no more to be part of our portfolio.
But now in the Europe, the clinical practice, some the physician or some the patient also use the gefitinib plus the chemo in clinical practice.
Not at all. It's mostly FLAURA2 and Mariposa, which are now being implemented in the routine clinical care in European countries.
Yeah, so but I think now we have so many the first line choice, such as the monotherapy, just Dr. mentioned, and then the manipolar and the osimertinib plus chemotherapy in China. We also have the bispecific antibody. So we have many So I would ask the Felip or the Nicolas, do you think which regimen is prefer the recommendation? So because also they will need the balance of the toxicity and balance of the benefit, but actually in the clinical practice, what's the prefer the recommendation? Yeah.
So maybe I can start. So I use Mariposa. This is my preferred choice because we have this wide efficacy across all the subgroups. And in some patients with very aggressive disease, I use the FLAURA2, especially with active brain mets. This is probably the group of patients where I prefer FLAURA2. And then OSI mono, it's only for elderly patients not amenable to escalation.
Yeah, I think very similar. So we consider as a first option combination in the first line setting. I think Mariposa has the rationale that we treat EGFR, and the mechanisms of potential mechanisms of acquired resistance, and is a chemotherapy-free regimen, and also we have the subcutaneous formulation. But yeah, we discussed with the patient both Mariposa and FLAURA2. I think the main discussion probably is in the second line scenario, that you have all the potential treatment options, no? So, but in Europe, this is not the case. So the reality is that for those patients previously treated with osimertinib, they're only approved by EMA is chemo plus amivantamab in second line, and I would use this in the patients that progress to first-line osimertinib. We need to discuss what would happen for those patients treated with FLAURA2 and also Mariposa-2 as the second line, but I'm impressed with the results of chemo plus ivonescimab and also with sac-TMT.
Yeah, I think when we are look at the patient, the characteristic, we are find the patient in the Asia may be the younger than the Europe. And then we have so many female patients, they're younger, but most of the patients claim they want to return the walk and return the familiar. So they think that the menopausal and the FLAURA2, they're every 2 weeks, every 3 weeks, they want to the also hospital. So they don't recover from the walk and then don't return to their home. So I think maybe we need confirm which patient really need the combination. I think for all the patient, the combination I think is not so good the choice. This is my opinion. Yeah.
Thank you, Professor Wu and Professor Girard and Felip. So I just follow that Professor Wu's clue. So we just focus on the balancing efficacy and safety. So my question is that the combination therapies improve the response, but bring more toxicity. So how do you decide which patient is truly fit for the combination therapies for Dr. Su Chenxia and Dr. Zhou Jianyang? Dr. Su, please.
Thank you, Professor Song's question. And I actually totally agree with our international speakers that if there's no other reasons like the patients with a poor performance status and it's an elderly patient or patient not willing to accept a combination treatment, I will give them combination treatment because we have the data of FLAURA2 and Mariposa. And I think I agree with Professor Wu's idea. Although there's maybe a higher rate of toxicity with these two regimens, I think maybe for Mariposa, I think I like sub-Q treatment. So with that, we will have a good efficacy and we will have a less side effect. And I totally agree with Professor Felip that actually we find few patients with when the resistance happened, they will have a bypass resistant mechanism. So I think maybe for the our patient, the overall survival is ended by each time of each PFS data. So I think maybe for first line treatment, we need to give them combination treatment. And after that, we need to think carefully and try to find a more precise treatment for our patients later line. So with that, we will have a best chance to give them a best overall survival. So that's my opinion. Thank you.
Thank you. So please, let's welcome Professor Zhou Jianya. Professor Zhou?
Yeah,
Okay.
yeah, I'm here. Yeah,
Okay.
dear Professor
What's your
Wu and
opinion?
Professor Phillips and Professor Gerard. Yeah, I think I wanted to, if we wanted to prolonging OS, I think it's based on the risk strategy.
Well, I think that the most important endpoint for these
Because we
triage.
think it's a high risk patient, such as brain metastasis, L858R, TP with 53 mutation. We also prefer the combination osimertinib plus chemo or amivantamab plus lazertinib for this kind of progressive front control. If the patient is a low risk or less fit patient, I think the osimertinib monotherapy to maintain a long-term quality life. But for me, I think always will have some problems. Which kind of combination strategy we can be prefer is if the patient have some MET abnormal, even in the de novo is a MET amplification or the MET protein expression is very high. We can use the Mariposa this kind of this way, or still use the osimertinib plus chemo. So I just have a question for Professor Gerard. So, which one you will be prefer to use the first line of Flora 2
That's a very
Mariposa?
Yeah, I understand. I think it's not an easy one, but it depends on the characteristics of the patients, as we discussed. It depends on the aggressiveness of the disease, and also we are moving towards more molecular decision making. We have seen the top study that was presented at ELCC, very nice study with chemo plus osimertinib in patients with EGFR and TP53 commutation, highlighting the benefit that we can get. So it's not a response to chemo plus OSI versus Mariposa, but at least it shows that having studies dedicated to these subgroups is very important.
Thank you. Professor Li Ziming and Professor Qiu Guibing, what's your points about this? Professor Li?
Okay. Yeah, I'm here. Yeah, okay. Thank you for Professor Song's introduction. And first of all, thank you for the invitation for this conference. And as we know that for the EGFR-mutant non-small cell lung cancer patients, we want to extend the overall survival. So this is it's an evaluation of the efficacy and the safety and the patient characters. And we want to develop a sequencing strategy can span the entire treatment journey. So we know that from first line, we move monotherapy to the combination therapies. So we can choose the Flower 2 or the Mariposa strategy. But we must think about the safety profiles and the toxicity management. And we know that if for the poor performance status and for the elderly patient, maybe we can choose the monotherapy. But I mean, for the most of the patients, we can use the combination. We just mentioned about the how to choose the patient, maybe for the co-mutations about the TP53 and for the brain metastasis, and then we can see that the combination for the chemo and plus the TKI is the best choice. And also we know that the different which I choose the first line treatment, we must think about the drug resistance, because we know that the chemo plus the EGFR TKI like the Vall, the mechanisms of the drug resistance is totally the same with a single EGFR TKI, but the Mariposa schedule with the drug resistance mechanisms is totally different. So we must think about the patient, the characters, and then we must choose the how we can do the decision making, and we can help our patients to get the best efficacy. So that's my point. Thank you.
Thank you, Professor Chow. My question is that for first-line therapy, how many % of patients you use combination therapy in your clinical practice? Professor Chow, are you there? Chow Guibin, Professor Chow. I think it may be something wrong with this online. Okay, so we move on the final question. I just want to know that after progression on first-line therapy, we can see that chemotherapy, chemo angiogenesis, and AMI-based regimens. So, and also we have a lot of clinical trials. So my question is that, what's your currently next line strategy for this kind of patient? So we from Professor Jia Yongxu first. Okay, Professor Jia. Okay, please.
Thanks for the introduction of Professor Song, and thanks for your question. It's a great honor to join this meeting. Actually, my research direction is gastrointestinal cancer, so it's a rare opportunity for me to have this chance to study with so many lung cancer experts from worldwide. So it's a great honor. In today's speech, I learned a lot. First, from the Professor Nicolas, the speech we see the Mariposa study have the perfect data and have the PFS exceeding 2 years, and preventing the resistance caused by the MET amplification in advance. So I think it's an ingenious design and have high efficacy and lower side effects. However, I have more interesting with the Dr. Felip's topic, also similar with the question of the Professor Song. If we have so many drugs, so many regimens, what is the best sequence? What is the best combination? Based on the data of the Mariposa, we can see the PF elevation from 22 months to the 25 months. We see the improvement over 3 months compared to the ositinib. However, in the second line, amivantamab can improve 4 months compared to the chemotherapy. So my question is, would a sequential strategy should be superior, especially in combination with the immunotherapy, just like the OptiTROP-Lung4 study, Harmony A study, that strategy after the resistance of the ositinib, we choose the avantilizumab combined with the immunotherapy. What's the best partner of the avantilizumab, and what is the best sequence? That is my question, Professor Song.
The question for who? For
Dr. Nicolas or Felip or Professor Wu.
Okay.
Again, I think this is a matter of subset. Right now, in those studies, we have exploratory subsets. We have brain mets, liver mets, TP53, but we don't know if TP53 have more brain mets or more liver mets. So it's exploratory, but so this is how we base the decision making on a daily basis. Obviously, I believe that having more dedicated cohorts would be great. And again, the top study to me is the perfect way to move forward. Obviously, in the top study, we would have liked to have FLAURA2 versus Mariposa, probably also to see in those patients, frequent patients with TP53, what we have with those two options. But now that the two options are available, I think it's the right way to start. And obviously, in China, you have so many patients that it's probably a very unique opportunity.
Yeah, I think the second line scenario is a very interesting one, and also, as mentioned, you have a lot of opportunities, here. So, yeah, probably there are a number of things to take into account. For me, as I mentioned, in the second line after osimertinib alone, that will not be longer the standard of care for all the patients. I'm impressed with chemo plus AMI, but also with chemo plus ivonescimab, and also with sac-TMT. So there will not be randomized trials among these different options, and also our first line is changing. So probably we would need to consider the treatment, the first line received for the patients, and also the chemotherapy-free interval also, and some mechanisms of resistance, and we will need to individualize. But again, could be interesting to have different treatment options, because even these options will be given in the patient in a sequential way.
Thank you. Professor Zhao, I think I just want to know the Professor Zhao's question. What's your answer, Professor Zhao?
Which question?
Professor Jia Yongxi's question. She said that how do you do the best choice for second line therapy? Which patient do you choose? Which kind of patient do you choose?
For the I think right now we have many regimen for the second line. But I think if I have a patient, I will ask him whether he want to get a biopsy. If no biopsy, I think I suggest patient use the Mariposa 2, because that's the overall response and the PFS is very good. We don't need to recheck the genes for the patient. But if patient allow to take another biopsy, I think it's another good choice. But if they found the MET amplification, I will use the such regimen for the patient of the combination of the TKI. But maybe in the future, I think the SKB 264, yeah, the TROP2 ADC is pretty good for the second line. Maybe it's also a good choice for us.
Okay, yeah, and thank you. So your point is that rebiopsy is very important, for most patients, but the chemo still the backbone. New drugs, new agents will be promising. So I do agree with your point, because the time is so limited. So I'm very happy to invite Professor Wu give us great comments. Professor Wu, please. 吴教授，吴老师。
I think thank you so much for the presenter, Dr. Girard, Dr. Felip, Dr. Zhao, and thank you all the combination, the discussion. We have so many the questions and so many debate on the first line and the second line treatment, because now we have so many choice. But I think we have choice. This is the good thing, not the bad thing. So, but I think now in the future we need to now maybe we want to based on the subgroup analysis or another biomarker analysis to confirm which patient is fit to the fit regimen. So that if we can do this, I think this is the good news for the patient. So I think this is the future. And then I also think that maybe in the next 2 years, we not only the 3 choices, maybe we had the 4 to 6 choices in the first line setting. So, but I think this is the good thing. Thank you so much. Yeah.
Thank you, Professor Wu. So for Professor Girard and Professor Felip, could you give us closing remarks, please?
Well, I think we have had so much discussion. I would like to thank everyone, all the participants, and you all for raising all those questions, because it shows that we have a lot to learn from each other, and this is best of ESMO. ESMO is one partner to have this kind of discussion. So thank you for that.
And same here. Thank you so much for the opportunity to participate. I think you are leading this space of EGFR mutation, so we have learned a lot of your work. And thank you also for all the new agents that you are developing, because it is an opportunity to have all these compounds for our patients. So thank you for the opportunity to discuss with you all. Thank you.
Thank you. So I think we have to closing this meeting right now, so we can see you again in the next meeting. Goodbye.
Bye.
Bye-bye.
Bye-bye.
Bye-bye. See you.
Bye-bye.
Bye-bye.
Bye.
Bye-bye.
This concludes today's meeting. Thank you to all the experts for their excellent presentations.